Thank you very much, everyone, for inviting me here, and also thanks for the hospitality. So I'm going to talk about the penile vascular Doppler, and this is the organ that we use regularly, but we take care rarely. So my patients come to me with a complaint of not having much time. So I will also try to finish my topic within 14 minutes, like my patients. So I have nothing to disclose, and so my patients not only comes with the erectile dysfunction-like cases, they also come with different topics. So we will try to share some cases with you so that you can think beyond the erectile dysfunction while doing the penile Doppler. So for some cases, we will go for the use of injection piperacillin or vasodilators, and for some cases, we will avoid that thing. And I'll try to share some of my experience with you. So we will use the injection piperacillin in the erectile dysfunction cases when needed. And also for some cases, we go for the sildenafil or tadalafil orally. But for these oral drugs, we have some limitations for the environment which our hospital can provide. So that's why we prefer piperacillin in most of our cases. So let me show you some of my cases. And this is the first case of 40-year-old male patient who came with erectile dysfunction. And this is the flaccid state where you can see the cavernosal arteries are showing some flow as like the normal penis. But after the injection piperacillin, we evaluated the patient. Up to the 20 to 25 minutes, there was no rise of peak systolic velocity of more than 25 centimeter per second. So we extended our examination up to 35 minutes, and there was still no hardening of the penis, and there was no increase in flow, which goes in favor of arteriogenic erectile dysfunction. Another case of 42-year-old male patient who also came with erectile dysfunction. In flaccid state, we can see some flow within the cavernosal arteries, and then we put some injection piperacillin. And after 5 minutes, you can see slight rise of velocity. And after 15 minutes, we can see a very good amount of flow with a peak systolic velocity of more than 25 centimeter per second, which excludes the arteriogenic cause, but still the penis is not hard. So we looked at the diastolic flow, which is still more than 5 centimeter per second, and after 30 minutes, we also scanned again and again, but still there is the increase of diastolic flow more than 5 centimeter per second, which actually suggests us that there is a presence of venous leak, which is called the venogenic cause of erectile dysfunction. Now, beyond the erectile dysfunction, there is another case of 52-year-old male patient who came with persistent penile erection for 3 months. I don't know how he stayed for 3 months in home. So when we scan the patient, you can see these are the cavernosal arteries, which are completely collapsed. So that took our attention. Our clinician wanted to use some tadalafil to see some flow. I don't know why. So he suggested that. So we used that. And after 30 minutes, 60 minutes, we again checked the patient, but still there was no actually flow within the cavernosal arteries, which is actually the thrombosis and collapse of the cavernosal arteries known as ischemic priapism or low flow priapism. Another case, we get it before the holiday season when the foreign workers come back to their home and they make this situation. So 41-year-old male patient who had a pain during intercourse, just 1 day after that, he came to us. You can see there is a mass-like area over here. This is actually the thrombosed or thrombus within the superficial dorsal penile vein. You can see on long section, the surrounding vascularity is increased due to edema and inflammation. And this whole thing is the thrombus within the superficial penile vein, which is known as the Penile-Mondor's disease. You see this thing commonly in the breast, where we also see the Mondor's disease. So it happens in the penis also. Okay, so another case, this is a 24-year-old male patient who had a history of sexual trauma and came to us. We can see this is the left corpus cavernosum, and you can see there is an echogenic area over here within the corpus cavernosum on the left side. So this structure is nothing but the hematoma within the corpus cavernosum, which is a case of grade 1 penile fracture. Another case of 45-year-old male patient with similar complaint. You can see a perialbuginal hematoma over here. And here you can see a gap, hypoechoic gap over here, which is actually the rupture of the tunica albuginea. So this is known as the grade 2 penile fracture. So this is a 48-year-old male patient who also came with similar complaint, but there was an additional complaint of hematuria. So we looked at the corpus spongiosum. Here you can see a heterogeneously hypoechoic area, which is nothing but the hematoma within the corpus spongiosum, and there is a gap over here, which is the tunica albuginea tear. So this is the grade 3 penile fracture where there will be the trauma of the corpus spongiosum. And here another case, this is the corpus spongiosum. We are checking from the ventral aspect, and you can see the hematoma extends up to the mid part. The patient complained about the hematuria also. And in this case, unfortunately, the trauma involved the urethra, which is known as the grade 4 penile fracture. So for the penile fracture grading, we have 4 grades, so from grade 1 to grade 4. Involving the defects of tunica albuginea or corpora cavernosa to be 1. Then there will be a hematoma perialbugineal on grade 2. If you see the involvement of corpus spongiosum, you go for the 3, and if there is vascular or urethral injury, we go for the 4. So another case of a 32-year-old male patient with painful erection. This is a very common case in our Southeast Asia, I think. So here you can see echogenic calcific plaques at the dorsal aspect of the tunica albuginea. So this is the calcific plaque, which is you can see here from the longitudinal section also. So this is called the Penile disease, where we see a calcific or fibrous plaques within the tunica albuginea. This causes the painful erection and bending. Another case of 10-year-old patient in my country, circumcision is commonly done. So this patient is also circumscribed. And so here you can see the distal penile skin is thickened and edematous. When we put the Doppler, you can see a very high vascularity. You can see corpus spongiosum cavernosum at this part. So this is a high vascularity within the penile skin known as posthitis. This is an inflammation which may come in association with the cystitis. I think this is my last case. So this is a 58-year-old male patient who came with a soft palpable lump in the penis. So you can see some mobility here due to the sound beam, and there is some debris over here. So this is located within the skin of the penis, and when we move the probe, you can see this lesion is compressing the distal urethra over within the corpus spongiosum. So we expect some urethral dilatation in this patient. So here you can see the proximal urethral dilatation also. So this is a case of penile skin abscess, which is causing compression of the proximal urethra dilatation. So that's all for my today's session, and I would love to say that penile ultrasound can go much more further than erectile dysfunction if you use the Doppler. And I asked my colleagues from different parts of the world. They say that they get rarely penile cases. Patients didn't complain much in last years. But in my country and in Southeast Asia, this is the organ we actually think a lot of. So I would love to thank also my Nepal colleagues. This is my picture from my final post-graduation exam, where among these 5, 2 are from the Nepal. So I'm very glad to have Nepali friends with me. So thank you for being so much patient. Thank you.